The second question being of high interest, stage 2 and stage 3, right? Classically and traditionally resectable non-small cell lung cancer patients, I guess, is a little rhetorical on why they should be referred to a medical oncologist, because we're talking about these potential neoadjuvant or adjuvant settings. But on the flip side, we see it all the time that they're not being referred. And I think that's, becomes challenging. It puts you in the pit of your stomach, because I've already seen patients now that come back, sadly with a recurrence. And I at least know not to ask the patient, oh, you didn't go see a medical oncologist, or why weren't you sent? Because that's one of the most injurious things you could ever ask someone. You're stating out loud that, a little bit of injustice here, potentially, should it have been the guideline at the time. But without me hopefully just answering that just now, why should we have stage 2 and stage 3 referrals to medical oncologists?
Of course, we have multiple FDA approvals now in the perioperative space, right? So the neoadjuvant and adjuvant setting for our patients. Every stage 2 and 3 patients should be discussed ideally in a multidisciplinary setting. So not all institutions have that, right? But get on the phone. The surgeons who are referred these patients sometimes after biopsy, they should get on the phone with their medical oncologist and discuss the case. However they can, I think it's really important that this be reviewed in some way. And the medical oncologist should have some input. We need to get the molecular testing also, right? We know that perioperative immunotherapy is not for all patients. And so getting at a minimum the EGFR and ALK status on these patients. But I think if we can do NGS testing, get that data, help that inform our treatment decisions, I think that's really critical. But I think as we're moving forward as a field, we're going to continue to get these referrals in, and we need to encourage our surgeons to send them to us.
1,000%.
Yeah, I'm excited about this question. I would argue that even a stage 1 should probably see a medical oncologist. I mean, in lung cancer, we don't cure as many people as we think. And so I think preparing for recurrence is something we want to do early, and I'd rather be over-prepared than under-prepared. Often, if someone has a stage 1A, while we might not recommend systemic therapy, we may recommend differences in monitoring. EGFR, ALK, high tropism for brain. Maybe we should do an MRI of the brain once a year. Maybe we wouldn't say stop surveillance at 5 years because there are data to the contrary. And so I think we can play a role and help those patients earlier on. I think everyone with cancer should have an oncologist.
Yeah, and it has to be a big plug for trials too, because you never know. There could be, not all trials are therapeutic, but it could definitely be, should we be getting these brain scans? Should we be doing circulating tumor DNA? And we can get a lot of insight in that manner and have it, without economic or at least financial toxicity, hopefully by being over vigilant, as some may arguably call it.